Hey everybody, this is Matt Erpelding from the Boise Metro Chamber of Commerce, and today we are excited to have a conversation around technology and the future of healthcare. The challenge with technology and the future of healthcare is that COVID has forced it even faster than it was already coming, and today we're going to be talking about some of the strategic changes that have occurred over the last 6 months, plus what we see happening in the future. But before we get started, I'd like to just remind everyone that the Boise Metro Chamber of Commerce is Idaho's only 5-star accredited U.S. Member of the U.S. Chamber of Commerce. And we are dedicated to advancing business in the Treasure Valley and ensuring that our members have high quality educational opportunities, hence today's seminar. Today's event is sponsored by Tandem Diabetes Care and Smith & Malik Attorneys. Both are dedicated to improving healthcare in the Valley and engaging in improving businesses in the Valley. And before we get started, I'd just like to give you this message from Smith & Malik.
I'm Luke Malik at Smith Malik. We set out to create a different type of law firm, one that changes the world for the better, as shown through initiatives like offering 12 weeks of paid parental leave for all full-time employees and providing pro bono legal advice to small business owners impacted by COVID-19. Healthcare is a core practice area, and we help our clients navigate a fast-changing business environment so they can make the most of opportunities with confidence. We hope Chamber members will keep Smith Malik in mind for all of your business needs.
Today, we're very excited to have 5 panelists with us. And before we get going, I'm going to briefly introduce them and read their bio. And I'm starting with Landon Reese, the Vice President of Product at Healthwise. A proven product leader, Landon's background in software as a service and product strategy is an excellent fit for Healthwise's mission to stay on the cutting edge of health education technology. Before joining Healthwise, Landon was a senior director of product at truckstop.com, driving the strategy, roadmap, packaging, and pricing of the company's product line. He's also worked for HP, where he served in a variety of roles. Landon's a native of Boise and is passionate about helping his community. He currently serves on the board of directors for Friends of the Boise Zoo, and he describes himself as a huge fan of the Boise tech scene. He graduated from Santa Clara University with a bachelor's degree in electrical engineering. And also with us today, we have Heidi Hart. Heidi is the Chief Executive Officer of Terry Riley Health Services. Heidi began her career with Terry Riley Health Services in 1993 as a therapist, providing specialized outpatient counseling and treatment services. She transitioned into leadership in 2001, serving as the behavioral health director until 2012, when she became the CEO for the health services. Heidi's a native of the Treasure Valley and graduated from Meridian High School. She got her BA at Whitman College and a master's in counseling from the College of Idaho and an MBA through OHSU in Portland. She's also the chair of our Boise Chamber's Healthcare Advisory Board. Heidi, it's great to have you today. Next up, we have Dr. Waj Nasser. He's been practicing medicine for 24 years and a board certified in family medicine. He's a co-founder of St. Luke's Capital Family Medicine, the medical director for patient care experience for St. Luke's, and he did his residency at the Family Medicine Residency of Idaho. He graduated with a physics degree from Middlebury College and his MD from the University of Louisville. Welcome, Waj. And last but not least, Ian Harris is the president and CEO of Vinyl, a product strategy and development firm that partners with companies in healthcare, finance, and insurance to help them design, build, and operate innovative digital solutions. Ian's held executive roles in product management, product marketing, and corporate development. He was a member of the founding leadership team and executive committee of the Los Angeles Clean Tech Incubator. And Ian is a decorated combat veteran who served in the U.S. Marine Corps in Iraq and Afghanistan. And I'm so excited to have this group here today. It's such a diverse group of expertise, and I really think that our conversation today will bring value to our community. But before we get started, just a really quick check-in. How are the 4 of you? And we'll start with you, Landon. How are you handling this new world that is COVID-19?
I think I'm handling it as best as we can and trying to do it for our teams too. So just like I think a lot of folks are probably on the call, I've got young kids that are here with me in the house virtually learning. We've got work that's still moving forward in a new way. Healthwise hadn't done a lot of virtual work before, so it's a new arena there. And so a lot of opportunities to learn and grow. And, hopefully as we move forward, maybe we can keep some of the things that we've learned that were better and let go of some of the things that we might not miss so much.
Nice. Heidi.
Landon was very eloquent, so I get to follow behind that. Much like Landon, I think it's really about just trying to deal with the immediacy that COVID presents, but at the same time, keeping our eye on future state, that we will move through COVID and we need to keep work moving forward. And so not to be paralyzed in COVID and our responses, but to really keep moving forward. Unlike Landon, I don't have little children at home, so I'm not trying to balance being a parent as far as a teacher goes, as well as being an employer. So I don't have that added burden, but I do get to support a lot of employees that are in that position as well. So I know together we're all going to get through it. And I'm just impressed by the spirit that people bring to the table.
Dr. Nasser.
We've been well, Matt. Our staff has been healthy. My wife and daughter were fine at home. I'm pleased that we've been able to transition our clinic in a way that we're able to meet the needs of our patients after being stymied there for about 4 weeks at the start of this back in March.
Great. And Ian.
Well, I think, I'm doing about as well as I can given the circumstances. In my house right now, as we're on this call, I have 4 kids. 3 of them are on Zoom doing school. One of them is 4 years old, so she's probably running around, without any clothes on or something, trying to find a snack to eat while she's watching a show on TV. My wife, who's actually a psychologist for a local school district, she is probably on a Zoom meeting doing counseling, or doing a telehealth appointment essentially with a patient right now. And so I just hope my internet holds up, and I'll warn you in advance, there's a 50% chance that a child with no clothes on will jump on my lap in the middle. And if that happens, we're just going to have to roll with it. That's the new normal.
Yeah, absolutely. So today we're going to talk about a breadth of issues, but I'd kind of like to just start with you, Landon. Give us a little bit about, can you help us frame up what telehealth is exactly, and how has this new healthcare interaction shifted your perspective on healthcare through Healthwise's lens?
Sure. Ian already kind of started a little bit, right, with what his wife's doing. Telehealth is kind of what it sounds like. It's a virtual interaction between a care professional and either another care professional or a person they're trying to care for. You're hearing about it a lot now because of COVID and the use that came out of it, and some of the things that I'll talk about in a second here. But I do want to say it's been around for a while. I literally was just reading a report from the World Health Organization about how telehealth or virtual visits could really help in developing countries that might not have access directly for like in-person care. And this report was published in 2010. So it's been around for a while, but in the US specifically, it was fairly heavily regulated and also didn't get a lot of reimbursement except for specific use cases. In the pandemic today, those are the things that have changed. The regulations have loosened. They actually have allowed technologies that we use in normal consumer experiences like FaceTime and Skype and Zoom. They allowed those even for a while. And we think that as the regulations go, we hope that they'll continue to have them be relaxed so more technology solutions can be in place. During this time frame when the pandemic when we really were in lockdown around April, like we at Healthwise saw a huge increase in telehealth visits and usage. One of our larger clients averaged somewhere around 1,500 telehealth encounters per month before COVID-19. In April, they saw 300,000 just in that month alone. And then now it's balanced out a little bit as they're trying to blend what makes sense for what situation, but they're still seeing 200,000 a month since then. And so with the pandemic, it's really given an opportunity to try out this new technology. And frankly, what we're seeing from usage is that for certain use cases, people like it.
Wow, 200,000 a month from 1,500 is a huge increase. And, Heidi, when the pandemic started, Terry Riley Health Services is dedicated to providing affordable healthcare to everyone, everywhere. And when COVID first started, you all put out information indicating that you were really ramping up your telehealth services. And my question for you is, did you see the same level of impact? And on the flip side is research indicates that telehealth, access to telehealth really can close the healthcare gap, particularly in rural communities. Have you seen that come to fruition, and how much are you doing in your practice?
Sure. So pre-COVID, we actually didn't have any telehealth services within the corporation. So in that regard, we were a little bit laggard compared to some of the other healthcare entities. We had a meeting on a Monday, and I said I need telehealth by Tuesday. And so our team rapidly deployed telehealth, and we did our first telehealth visits within about 24 hours of kind of the declaration that the pandemic is here and we need to pivot and change. So I am very grateful that a lot of people, both patients and providers, quickly adopted to the technology and put it into play. And I think part of what we have learned in that process over the last couple of months is that there are places, as Landon suggested, where telehealth is really effective, and it's a great means of providing healthcare. We find it really good, especially in behavioral health, where you can do psychiatric visits or counseling services. There are places, though, where telehealth is really probably not the right strategy. You think of things like well health checks or preventative health exams or immunizations and vaccinations or dental services. You clearly can't use telehealth services for those kinds of activities. So part of what we're on is the strategy right now of trying to figure out what are the best use cases for telehealth, and then what are the places where in-person care is really the right strategy moving forward. I would say one of the challenges that we're running into a little bit in rural health is around broadband and access. Not everybody has really good internet coverage, and not every home has computer or technology capabilities available to them. And so even in those circumstances where telehealth might be the right strategy, we may not have the infrastructure or the resources to be able to do that. And then certainly, I think about one of the remarks that was made, and that is when telehealth is not appropriate, you think about if I'm a 5-year-old little kiddo running around trying to do a telehealth visit, I probably am not going to be, it's not going to be a very good visit using telehealth. So I think the team is still trying to figure out the work in progress and the workflow to best implement it so that it's good for everybody.
Waj, Dr. Nasser, building off of what Heidi and Landon said, Idaho between March and May of this year saw 117,000 telehealth visits, as opposed to 3,000 telehealth visits in the same time frame from last year. I'm sure that this has impacted your practice, and as you see it, what are the strengths and weaknesses of telehealth coming from a primary care provider?
Yeah, that's right, Matt. We've seen a big ramp up in our telehealth services. In our clinic, it accounts for about 29% of all of our visits now, which we're really pleased with. I think the advantages primarily pivot around access, and when you have better access, I think you have better care, and even though a lot of technology is not in place to create more robust encounters, there's still a lot that can be done. From a disadvantage standpoint, there, relatively speaking, it's modest stuff. It's, I think just trying to work out the kinks in terms of the interfaces, and as was mentioned, people having computers and internet access in order to avail themselves of this technology. That's a problem. But when I think about telehealth, I really think about all the promise of it.
Ian, Heidi mentioned a big issue in Idaho that is not on the healthcare side, but it's on the access to internet side. We've got a lot of areas in the state that are operating with speeds that are just slightly faster than dial-up in some cases. But from a technical solution perspective, what are some of the major pinch points that your industry is seeing in terms of being able to deliver high quality healthcare, telehealth care access? What are the pinch points that you're seeing in terms of providing solutions?
Yeah, well, I think, she touched on some of those things, obviously, especially in rural communities, broadband access and just access to devices that can facilitate these types of encounters is an issue and something that needs to be worked on. I think I think the biggest issues have to do with safety and security, compliance, access to the tools, and then, obviously the basic user experience, right? Making it frictionless, making it easy for people to use. I think a lot of people before COVID, and so one of the things that's changed recently, is that, people had this conception maybe of, teams of teledocs, right? Who were remote, that worked in some type of a specialized center or whatever, or had, specialized training where all they did was take telehealth appointments, and that, the doctor that you're talking to may be, really, far away, right? Maybe in a different state. Whereas today, what we're seeing is that there's, this shift that's happened very rapidly toward sort of enabling people to talk to providers that are, maybe in their neighborhood. So, it's not that you're talking to a doctor in some call center far away. You might instead be talking to, your doctor, right, who's just down the street. Which means that as you're implementing these solutions, it's not about some big centralized, platform somewhere necessarily, but you have to enable people in all sorts of different places to take these appointments. You have providers taking appointments from their home, right? Obviously, you have people, patients, right, taking appointments from all sorts of different places. And so the question is, how do you make sure that those connections are safe? How do you make sure that they're secure and free from any sort of interference, right? How do you make sure that, people aren't being recorded, information isn't getting sort of leaked out there, and then how do you make sure that you're doing all of that and capturing all of the information and the data that you need to capture and feeding that back into all of your core systems? Those are the big questions and pain points. And the final one I'll say has to do with user experience. In our business, as I see startup, so I see a lot of startups pitching, great solutions that have to do with digital health. And, whenever the solution is, well, and then the doctor in the exam room is going to open up this separate device with a separate screen that's outside of their normal workflow, right? Then, everybody kind of says, oh gosh, the clinician's not going to want to do that, right? Or anytime that you say, okay, well, then this information will go into this central repository and it'll be manually moved over to another one, right? Oh gosh, nobody wants to do that. And so I think that's been sort of the biggest question, is how do you take these new telehealth systems, right, and these new telehealth workflows, and how do you work them in so that they're sort of integral and integrated within the current systems, within the current processes that are already in place as much as possible. And I think that that'll be sort of the next frontier. It was touched on earlier. We've started out with people using Zoom or Skype or FaceTime calls, and going forward, the question will be, well, how do we replace that or augment that with things that are integral to the systems that we're all already using, both as patients and as providers.
Landon, I mean, the conversation around the lack of fidelity between a face-to-face meeting versus an in-person meeting, and the value that brings, and then the other issue that's currently being faced by so many families, which is in an inpatient setting, often no one else can go in with the patient. And so what is Healthwise doing to help kind of close that gap, or what are you all trying to do to help ensure that the same amount of value comes from a telehealth visit and an in-person visit?
Yeah, so I think I'll start by just recognizing that, as we've said before, there are benefits to when you're in a telehealth space, but there's also some downsides, and there's the technology is a tool that you need to implement where it makes sense. And some of the benefits for where telehealth may make sense that Healthwise is really thinking about is how do you actually go beyond maybe just the visit and start to think about tracking engagement and getting that information integrated into clinicians' workflows, maybe even giving that access to those care providers that might not be able to go into the room today, so that we can make sure that people are actively engaged in their care and health. And so we're a patient education provider. So, an example would be that in a telehealth visit, maybe you're getting educated about a new illness that you have, and you want to use education that came from Healthwise. Wouldn't it be great if, as you were reading it or if you were engaging in it, that the clinician would know that you engaged with it, or that the care provider also got it too, based on if they were authorized from a security perspective to be able to read it and help educate you if maybe whatever illness you had might not allow you to do so. And so with like digital platforms and things like partner portals, we really can start to get that information out to the right folks, and then actually measure that it's being consumed, which was a challenge that sometimes doesn't happen when you're in person. I'm fully will admit that I don't read everything that I might come home with every time. And so this allows us to start to think about how to get that information out, when to get that information out, get it in the ways that people are used to, like our phones and our other items today that might not have been there before. And so that's really how I think about some of the benefits that can come from a telehealth encounter that can help to counteract some of maybe the lower fidelity you get by missing some of the nonverbal communication that we have in person.
Ian talked a little bit about regulations, Heidi, and the governor. So I was in the legislature when we passed the first telehealth law, and it did have a lot of restrictions on it, in large part to kind of address, and maybe you can explain it a little better than I can, but address some of the issues around HIPAA, making sure that documents are secure, and that if you're doing a counseling session, nobody is recording it later on to be used against them, et cetera, et cetera. But the task force and COVID has kind of forced the state to loosen some of its administrative rules that were created as an outgrowth of the telehealth care statute. Talk a little bit about the governor's task force on telehealth care, what they're doing to increase access to virtual care and telehealth care, and whether or not they're addressing anything around issues of parity.
That's a lot. So I think I'll start by building really upon remarks that Ian started with regards to some of the issues that we see around telehealth or the implementation of telehealth technology in healthcare. If I think back about where we were pre-COVID, both as healthcare providers and as a regulatory entity, we were kind of incrementally working our way through the rules around how do you adopt and utilize technology and telehealth to deliver care to patients. With COVID, there was this rapid adoption of technology as everybody scrambled to really put telehealth on overdrive within the healthcare system. And, you know, we're really appreciative to a lot of people that were involved, whether it was government entities, payers, regulators, who really tried to push away all of the rules and restrictions to say, please just do the right thing for patients, utilize technology, and we'll figure out the rules and the protections that need to be put in place. And that we trust that you'll do the best thing for patients. So on one hand, we completely appreciate the flexibility. On the other hand, there is a need to still come along and create structure through the use of technology and telehealth to address many of the issues that Ian touched on. So I think part of the value for the telehealth work group is really to come along and be that steady force to begin to, or to continue to look at what are the rules and restrictions that we relaxed that we need to continue to put in place. Where are the places where we need clarifying answers to questions that surfaced as we quickly adopted technology? And then how do we disseminate that information so that, yes, we can absorb and use telehealth as a way to extend healthcare, but we do it in a way that still safeguards and protects the rights and health information of our patients. So there are a couple of things that I'm watching for in particular out of the telehealth work group. One of them is really, what is the definition of telehealth these days? Originally, we thought telehealth was an encounter where you had both audio and visual interactions with a patient. And what we're finding a lot is that sometimes people don't have that ability to have video. And so the encounter gets dropped to a phone call. Is that an eligible provider activity? Is that something that should be paid for and reimbursed? Is that acceptable quality healthcare? What about e-visits, right? So for some people, what you end up doing is having communication through e-technology, where you're emailing and sharing information back and forth, and maybe it's patient education information that you're discussing. Is that telehealth or not? And is that an allowable activity and something that is supported within the provision of healthcare? And what about the means of having technology for people that are hearing impaired? How do we make sure that people that have disabilities have the ability to access telehealth in a way that works for them? We're also looking for ways to make sure that payment methodology is aligned up with these new means of communicating and interacting with patients that we think make sense. So for example, as a health center, we're not allowed to bill most payers for remote home monitoring. And yet, in many instances, that's the best way to get information on our patients, is to understand what is their experience every day, and then how do we support our ability to provide these services. And then obviously out of the telehealth work group, we're really also working and paying attention to the support, as Ian mentioned, around broadband, to make sure that we have the connectivity, to make sure that everything is in place. So the telehealth work group is really the driver from my perspective about making sure that all the players come together to institutionalize all of the changes that we're working towards within healthcare as we adopt technology and make sure that it works for everybody. Oh, Matt, you're on mute.
Epic rookie move.
Sorry.
You warned us not to do
You're great.
it.
I was going to say, I just, the gist of this for those of you watching is that I was like, if you're on mute, someone's going to yell at you. So, Heidi, would you expand upon the remote home monitoring? What is that? In a second here, I've got a question for Waj about wearable devices and things like that, but remote home monitoring seems like it's even more in depth.
So I'll start it, and then I certainly would pass the baton to the great doctor who can answer and fill in, since I don't have the same clinical expertise. When I think of remote home monitoring, there are things like remote home monitoring around diabetic care so that you can monitor your diabetes over an extended period of time. If you are in preterm labor or at risk of that and you want to do some sort of home monitoring so that the provider can track your contractions and whether or not you need to come in. So there are a lot of ways that we can monitor an individual's health status at home. The question is, who pays attention to it? Who reads the data? How do we transform and connect the information into the healthcare system? So it's more than just wearable devices and how many footsteps have you taken, but really how do we get biometric data on a patient when they're at home and transport that information over to a provider so that they can continue to manage a patient's care outside of a face-to-face visit. So I'll pause there and say, how close did I get, Waj, into stepping into your domain?
No.
Yeah, Dr. Nasser, if you could build on that. I mean, there's so much to wearable devices and the future of wearable devices and how it can shift the relationship between the patient and the provider. For example, I wear a Freestyle Libre continuous monitor system for my blood sugar, and my doctor knows when I have basically misbehaved or eaten the wrong thing. But how has that shifted, and what potential does it have in the grand scheme of things?
Well, you bring up diabetes, Matt. You know, one of my patients is a physician. He's very diligent about his insulin-dependent diabetes, and he uses continuous glucose monitoring now, and he's learned so much about his diabetes. Up until about 5 years ago, and he's about 50 years old, he could not get really adequate control of his blood sugar. And now with this device and getting back that continuous data, he's at goal. We're not seeing low blood sugars with him, and it's been an extraordinary improvement in his blood sugar management. You know, right now it's mainly an issue of promise. What we're seeing clinically most commonly are people wearing things like Fitbits that are giving them information about their sleep patterns, their heart rate. So we'll get, it's not uncommon that a patient will come in and say, why was my heart rate up to 190 for this period of time? And, we sometimes we work through that and we're not convinced that the data is accurate. And so we have to be careful about how much credence we put into that. There are a number of companies that are where the technology exists to do more robust home diagnostics, looking at things like oxygen saturations, of course, blood pressure, but also listening to the heart and lungs, doing exams at home that can then be uploaded, and then we can do those exams remotely, and so that's something that I'm rather excited about. I think when you tie in our lack of understanding of what the data means, and I know we're going to talk about this a little bit later, it creates a problem because we're getting data, but we don't exactly know what to do with it. They have to go hand in hand, of course. But in trying to understand when we've got a sick homebound patient who may be having problems, and helping that individual identify that they need to come in sooner, be of great value. one of my patients emailed me, emailed our clinic on a weekend, just describing some symptoms that he was having. It turns out that he was getting septic, and he had no idea, and he lived alone. And so this was a very, very high risk situation. Thankfully, he had the wherewithal to send an email. But if we could have been remotely monitoring his blood pressure, his heart rate, his temperature, and then building in triggers for warnings based on our understanding of what that data means, then that's something that we could have conceivably identified well before he reached out for help.
That brings up a good point. St. Luke's uses the Epic software platform, and Heidi was talking a little bit about how we identify what is telehealth and what is just routine interactions with your primary care physician. How do you do that in your practice? What do you determine to be a telehealth interaction, and then what do you determine to be just general interaction that would be non-billable, I guess?
So much of what we do in primary care falls under the umbrella of non-billable care. So we're very used to that. We get on the phone and we talk to patients. We email patients. We just consider that part of our management. Nurses are talking to patients. We bring them in for blood pressure checks, sometimes informal follow-ups, and it all works out. Currently on the telehealth side of things, we've come up with a template here in our office where if the patient calls, we have about 60 different categories of visit types, and we can offer them a telehealth visit or an in-person visit based on what they're sharing with us, and so we try to triage it that way. And then, we have video visits with patients. Sometimes it doesn't work out. We have to transfer to a phone visit. Those are currently billable. And sometimes we'll get into a visit with somebody and we'll realize that it's not working out and then we have to see them in person. So we'll just cancel that and typically not charge them for that encounter, of course, and bring them into the office.
Ian, you hear there's all these different softwares out there, and I know Vinyl specializes in creating custom softwares for a host of different industries, whether it be healthcare, finance, insurance. But what are you seeing as the industries or the healthcare companies that are most interested in partnering on technology right now?
Yeah, it's an interesting question. We're lucky, I think, in many ways, because we get exposed to a wide swath of the industry. So in the healthcare space, we work with payers, of course, helping to work with them to make their member experiences better, helping them to better deal with and manage data and do new and interesting things with the data that they are collecting, that they have, helping to make sure that they're better collaborating with all their various constituencies, including providers and the companies that ultimately are their customers. We work with some pretty exciting research institutions that are developing new and interesting things like digital diagnostics or future sort of therapeutics or ways of measuring and helping people to manage different types of therapies. We work with some pretty interesting sort of venture-backed startups that are doing some cool stuff and sort of innovating around business models and how care can be delivered. And so we've really worked sort of across the spectrum of this industry, and that gives us some unique perspective, I think. I think one of the most interesting sort of things that I just heard Dr. Nasser talking about was this idea that we're starting to empower people and patients with all of this information via devices. Like I have an Apple Watch, right? He said a patient might say, "Oh, why was my heart rate up to 190?" And show them the information. And as a clinician, right, you don't know if you can trust that information or that data as it comes in. I've told a story before. One of the things that I get to do that's really cool is I get to try out all of these different new health technologies, right? As part of my job, and different type of systems. And one of the things I tested out was a solution where they did genetic testing and they did blood testing and they did all this other stuff to try to give me some insights into how my body processed food and other things. And I got these blood panels and all this stuff. And so I brought that into my primary care physician and I showed them this information. And she kind of said, "Oh, well, that's very interesting, right? Let's put that aside. If you want some information, why don't I order a blood panel, right?" And so a big question I think that we wind up asking ourselves is not just what can we build, but what should we build that'll work within the current systems. But again, I think that you're going to see a lot of really interesting solutions that are focused on empowering patients and patient experience, right? How do you make it more frictionless, I guess, or less, create less friction within that process? How do you empower patients to get information when they want it, when they need it? And how do you make sure that information is good and useful to the rest of their care team? I think that's the big area that we've been focusing on.
Ian, there's a question here that I think is probably best addressed to you because it is about the Apple Watch and kind of a question of when will Apple Watch be able to provide our healthcare information to our primary care, to our doctor in a secure way?
Yeah,
and I mean, you have an answer for that. I feel like you would be the one that might.
Yeah, I mean, I think Apple has done a lot in their ecosystem, and they have a huge focus on healthcare. We know that we've worked with Apple, pretty closely as they've been moving in that direction. You see it with the Apple Health Records, right? It's a very powerful tool where you can link up with all of your various providers and get access to your health records and have them downloaded, onto your phone. We use Apple devices like the watch, certainly iPads, in various settings to collect different kinds of information. One product that we're helping to build has to do with essentially early detection of certain types of cognitive disorders, things like Alzheimer's or forms of dementia. And we use iPads essentially to deliver tests that were originally developed using paper and were administered by a clinician sort of across the table from the person who's completing the test. And we've taken those and turned them into sort of digital tests that people can take. And what that's done is it's actually made the ability to sort of do an early detection of some of these things much easier, right? You can see the difference, right? That means when you make it digital, the tests are being delivered perfectly, right? The data is being collected and scored perfectly. You can see things like people's reaction speed and whatever else using the technology that the human eye can't necessarily see, right? You can incorporate things like eye tracking or other types of things. And so just across the technology spectrum, you're starting to see that the sensors and other things in these devices are getting so good that that they can be trusted. But again, I think security is something, especially within the Apple ecosystem, that they've done a pretty good job of.
That's great. Landon, when we talk about healthcare as a tool to manage out-of-pocket costs for patients, but also to improve their quality of life, technology has some real opportunities here. And what do you see on the horizon that will address those two specific things, the two big issues for patients?
Oh, definitely. I don't want to belabor some of the points that have been already made, so I'll just kind of say that Ian spoke a lot and Waj spoke a lot, Dr. Nasser, about kind of the health apps that are moving in that can help us work through some of our chronic condition management and how that can be engaged day to day. We talked a lot about remote patient monitoring and how that information could help us diagnose things earlier and have much more almost like a preventative based approach to some things that can get further along when we recognize it, maybe as someone who needs to send an email out. But some other ones that are kind of underlying that capability that I think are really driving that are important to mention. First is something that's called interoperability. It's a big word, but it really talks about how to make things easily work well together and to free up the data that's held between the EMRs like the Epics and Cerners of the world and the applications that are coming out from some of these startups that Ian mentioned and the other ones that are really picking up steam. And so the federal regulations are really coming into place that are prohibiting that information from being siloed. And so we're on the cusp of, and actually in the middle of, some really exciting investment in those spaces for these kinds of applications. The only one that we maybe haven't talked about today that I think is worth mentioning now is there's a lot of investment going into cost tools and to help people understand really how much something is going to cost as they go into it, so that really they can avoid that surprise billing as they go through. I'm sure we've all read a little bit about some of the stories, even around treatment for COVID, and how the variance in what can be charged based on your payer and where you are in this country. And so there's a lot with interoperability, with some of the regulations around price transparency, and then some of the value that software can bring in to reduce the complexity of healthcare pricing. I think we're going to see a lot of applications grow in that space too.
Heidi, you started out specializing in behavioral health, and that's really your background. And even with the Affordable Care Act, there's still 5.5 million children that lack any access to health insurance. And there's a common pinch point there in that often if they lack access to healthcare, they also lack access to a quality internet connection. There's definitely a connection there. But as you all have transitioned to doing your behavioral health programs through telehealth, what have you learned from that, and how is it working? In particular, I want to add one more thing, in particular, because mental health is so challenging in Idaho. It is a really difficult area that we continue to address at the policy level.
I appreciate the question and the focus on behavioral health. And you're right, it is a kind of a personal passion given my background. And I would say even within that, I have a special passion or concern for our pediatric patients or pediatric patient population. And I think one of the things that reminds me to stay grounded in that, I was visiting with one of the ladies in the office here who is a grandmother of a 7-year-old child. And the little kiddo went in to see the doctor for the well child visit and to visit with the provider. And the provider asked the kiddo, the little boy, and said, "How are you doing with all this COVID stuff?" And the little kid got really sober and serious in the visit with his provider. And he said, essentially, "I'm really sad. I'm really tired of being at home. I miss my friends and I'm really, really lonely." And, you know, I think that when I think about the kids, many of them have been out of school since March and have not had a lot of great social interaction with their friends. And especially for little kids, I worry about them getting lost and the long-term emotional well-being. And so when you compound that with the number of people that are uninsured or the number of children that are uninsured, I absolutely do have worry for the families who are trying to support young children and the isolation and stress that young children are facing. A couple of things that we're working on that I think are at least trying to be efforts to work in this space, as well as lessons learned within our organization. All of the health centers in Idaho collectively went in on a grant application and were awarded a federal grant that allowed us to hire, or is in the process of allowing us to hire, extra people within our team to reach out and work with families to help them apply for benefits and insurance coverage for their children if their children are uninsured. You'll probably start to see billboards going up across the state. I think they were starting to go up this week, just as a way to remind people that there are resources and people that can help start to bring down that number of kids that are uninsured, so that we can help get kids access into the healthcare system that does exist and the behavioral health service system that does exist within the state. I would say that much as I think it was Ian who mentioned that he's got a little kiddo running around the house, telehealth works great for adolescents and adults. So people that can have patience and sit and interact with a computer system or a phone to carry out a visit are great for telehealth or behavioral health visits. So it becomes a modality or a means that you can continue to extend behavioral health. But for younger children, it's really not a great strategy all of the time because of their attention span and their patience. I've had one counselor that was talking about trying to do a telehealth visit with a kid that was more concerned about showing the inside of their nose and their ears and walking around and seeing the dogs and all of that than having a meaningful therapeutic experience. So I think telehealth and trying to figure out how we use technology to reach our children is still a work in progress for us. And then I would say another area that I would put in the category of work in progress around behavioral health and children is really within the partnerships within the schools. I know our organization and many others have been partnering with schools to bring behavioral health to school and have it be part of the resources that are available to the schools as they're providing education to students. And as schools are trying to figure out their return to school plans and how are they providing for education, I think each of us that have school-based services are really trying to figure out how do we partner and come around the schools so that as children do return to the school system and have access to the teachers and the principals and the school counselors within the system, that we're there to be able to help provide services, whether it's on-site or telehealth. And right now, I think there's so many moving parts within the school system that we're just all trying to stay at the ready to try and figure out how we pivot and support the school districts. So I do worry about the behavioral health needs of our young members of our community, but I think there's a lot of us that are trying to figure out what's the right lane for telehealth and for the right group of patients within the system. So I put it in the category of work in progress, but I'm glad that people are worried about the well-being of our youngsters.
This question, I think, is probably for both you, Heidi, and Dr. Nasser. This comes from somebody who's watching, but they'd like comments on how telehealth and wearable devices and advanced technology can help with the transition from a fee-for-service to a value-based care program. And Heidi, why don't you start, and then I'll chase Dr. Nasser with another question.
Sure. So I guess I'll build on Dr. Nasser's remarks, and that is that there's a lot of things we do in primary care that are non-billable activities. And yet fundamentally, we have to figure out how to keep our business operating. And so I think one of the things that we're hoping for within a transformation around payment methodology is if we can start to be paid for the health of our patient population or the outcome and movements, then we can be less concerned about, did we document that this was a face-to-face encounter, or did you spend 10 minutes on a telehealth visit, right? So the more we can let go of those widget counting, if you will, within the healthcare arena and just really be thinking about what's the outcome that we're trying to achieve in our industry. In our industry, we're trying to achieve health and well-being. And so if we can get paid under a value-based system that says, achieve the goal, and we trust you to figure out the means, then I think that's what we're all striving for. And in that regard, then remote monitoring fits in very nicely because then it's really about this is what's right for the patient and helping them achieve their health goals.
And Dr. Nasser, same question for you, but I'm going to build on that. Artificial intelligence continues to make strides, and with all of this increase in data availability, how do you see artificial intelligence impacting the healthcare profession? And also, how do you see technology moving us from a fee-for-service to a value-based service?
I'm not sure I could put it better than Heidi. That was spectacular. It's rather, at times it can be very difficult to be there in the room with a patient, and you want to dutifully document, well, in the room with the patient or when they're conveying things about their health mat, and you want to reflect that in the chart, of course, and the patients oftentimes are keenly aware that that may correlate to how they're billed, which is it's just a terrible way to have a relationship with somebody. One of my patients one time said he felt like the meter was running, and we as clinicians, we in healthcare, we don't like that at all. So I agree wholeheartedly with what Heidi said about remembering what our ultimate purpose is in terms of taking care of our patients. Regarding AI in the primary care world, and I would limit my comments to what I do. I think it holds enormous promise, Matt, as initially at least, as a tool to help us diagnostically, to take all this data that our EMRs are now being able to provide us, and to begin to expand our insight into how a patient presents, understand that differently based on the data, and to make inroads in that. I think another area of promise for AI is competently managing so many of the tasks that a clinician has to manage right now. Should the patient get, and some of them are very banal, but they take up an enormous amount of our time. Should the patient get a refill request? When should the patient come into the office? We can use AI to really manage a lot of those ancillary tasks that I think contribute to clinician burnout.
I wish I could understand how artificial intelligence is going to work, but it sure does seem like a powerful technology. And Ian, kind of like a last question as we get into it. In a second here, I'm going to ask you all for your crystal ball, but one last question before we get to that. Ian, COVID has flipped the world upside down. And so what are healthcare companies actually asking for? What type of technology are they investing in, especially post-pandemic or during this pandemic?
Yeah, that's a great question. I do want to just briefly touch on what Heidi and Dr. Nasser were saying there as well about AI. I think what we're seeing is a big opportunity there to take all of that big data, right, and to try to identify people and populations who are at risk and sort of tag them for further evaluation, right, so that people aren't falling through the cracks, right. I think that is something that is a sort of a pretty immediate possibility on the frontier for those types of technologies. I also think maybe short of diagnosis itself, things like quality assurance or quality control around different types of diagnoses or around the evaluation of things like medical images or what have you. I think those are areas that could be really interesting. But to your question about sort of because of COVID, what we haven't seen a massive change necessarily in what people and what companies are looking for or asking for or trying to build or integrate. What we've seen is a massive acceleration, and so more and more. We've been talking about it for decades, right? Digital transformation and changing the patient experience and interoperability, right? None of these things are necessarily new, but what's happened is now we've had this forcing function where companies have been forced to try it, right? They've been forced to do it. They've been forced to implement this stuff, right? And I really think that the true answer to your question is that there's not much new, but that there's no stopping it now, right? It's just accelerated. It's moving more quickly. And so, we're seeing the same things, right? The organizations need, to make sure that they're interoperable. Organizations need to be able to sort of manage, their data pipelines, make sure that the data they're collecting is clean, make sure that when they're using it to lead to outcomes like recommendations for who gets care or what have you, that information is good, right? They're looking for ways of using remote monitoring devices. They're looking for ways of integrating telehealth within their current systems. It's all the same stuff. It's just that everybody's doing it now, right? I think all of the providers realize that they have to really be technology focused.
Yeah, it seems like it's here now and it's here to stay. So one last question for all of you, and I'm going to go backwards this time. Landon, you're going to get the last word here. But looking at your crystal ball, what is your biggest prediction for technology in the healthcare industry over the next 5 years? Ian, you can go first.
Yeah, biggest prediction, huh? Well, I think we've touched on so many of them, but I think the one thing that I'll touch on here has to do with that user experience, the patient's experience, right? The member's experience if you're the health insurance company, and I think that we really need to make sure that we're not losing sight of that. This industry is a bunch of people who are trying to work together and collaborate to make sure that people are more well and healthier. And so healthcare has been slower to change and to remove friction from some of these processes than some other industries. When you ask people, today, you say, well, where's your bank, right? For some people, they can tell you where their branch is. For more and more people, maybe they couldn't. It's in their pocket, right? You ask people where their car insurance agent is, right? And 20 years ago, they could tell you what strip mall they went to go to the office to meet with the person. And today they're like, I don't know, it's right here, it's in my pocket, right? And so I think more and more that's going to become the case, both in terms of how people think about their health insurance company, how people think about a lot of their different providers, about how people think about where their health records and information are and where things are coming from. And so I think that the biggest change and sort of continuous change that we're going to see is that we're going to have to be really hyper focused on individuals, right, on the patients, but also on the providers as people, and making sure that their experience is really smooth and frictionless, and really make sure that we're empowering both sides of that equation to do the things that they want to be doing, which actually lead to the best outcomes, rather than things that can be automated or things where there are extra steps that don't need to be there. And so I think that there's really going to continue to be a revolution around that user experience on both sides, and how we're empowering both physicians, right, and patients to drive better outcomes.
I like it. Streamlining. That's the gist. Dr. Nasser, what's your prediction?
Well, let me make a plug first for just basic implementation, Matt. Despite all the wondrous technology that we have, I would remind everyone that basic things like getting a flu shot makes an enormous difference in the health of our population, and to strongly consider that. I think the big headlines in the next 5 years are going to come from CRISPR technology and gene editing.
Great. Heidi.
So I'm actually going to answer it a little bit different because I could ditto on what has been said before. But I think one of the things that we'll still need to shake out is what's the balance between the human connection and the technological connection. Because I completely agree with Ian that there are places where we want it faster, crisper, more immediate. I want it in my phone. I want it right available to me. But there are also times where, as an individual, I'm hurt, I'm scared, I'm afraid, I'm worried, I'm injured, and I want to know that there's somebody that I can trust that will sit with me, care with me, and make sure that either I'm okay or I die with grace. And so I think part of the challenge is going to be what's the lane for technology and what's the lane for the human element that's at the core of healthcare and is part of what we come to value and appreciate about the healthcare experience. So I think the jury's out yet on where the balance is between technology and humanity in the delivery of healthcare.
And Landon.
I think my crystal ball is a little fuzzy, but I wanted to share some numbers to talk about why I think a lot of what we talked about will come to reality over the next little bit. So if you start to go look at like VC investment, you start to go look at where they're pouring a lot of money. If you go look at where all the big technology companies are investing heavily, Amazon, Facebook, Microsoft, Google, you're going to find a common thread around healthcare. There's over 150 digital health startups in the US alone that have raised over $20 billion in total funding across 600 plus deals. Wow. Yeah, healthcare is one of the top one or number two in terms of digital health, in terms of investment from a technology perspective. So I think what we're going to see in 5 years is that it's coming. And some of the ones that are there already will continue to grow in strength. And so the question is, will you have another kind of big five type approach? One of the ones is in the pole position today is like the Teladoc and Livongo group, which is now the two companies that are now one. It was an $18.5 billion merger that's still going through the regulations perspective. But when you think about what they did in terms of telehealth and then also chronic condition management, specifically around diabetes, I think you're going to see a pretty big fight for who's going to be the platform for this space. And so I think in 5 years, there's going to be a lot more clarity on how many platforms there are and who wins. And in these kinds of businesses, only one or two really win. So it's going to be a pretty wild ride for 5 years.
Oh. Well, first, I want to thank Landon, Heidi, Ian, Dr. Nasser. Thank you all so much for joining the Boise Chamber to have this conversation. I want to thank everybody who's watched us today and for engaging and for submitting questions online. We very much appreciate that. And last but not least, I really want to thank Tandem Diabetes Care and Smith & Malik for investing in the Chamber, for investing in quality educational programming and conversations around issues. We very much appreciate you and we're thankful for you. And to everybody out there, we'll be back next week with a B voting series with Congressman LaRocco and Congressman Labrador, followed by, at the end of the week, a conversation with city council members from around the valley on property taxes and city budgets. And so we will see you next time.